Welcome to Chapter 13, entitled Pharmaceutical Care in North America. Pharmaceutical care in the US and Canada is regulated at the level of the state or province, generating differences in the practice of pharmacy across the countries. Pharmacist counseling and utilization review are generally required to be offered at dispensing in community pharmacies. There is a trend toward the development of pharmaceutical care services provided at the community pharmacy, the integration of the pharmacist in the healthcare team, and the implementation of collaborative agreements expanding the role of the pharmacist in patient care. This chapter is divided into two sections, one for the United States of America, and one for Canada. We will focus on the United States of America. Let's begin with the community pharmacist in the U.S. In 2015, there were 65,280 U.S. community pharmacies, representing one pharmacy per 4,915 people. U.S. community pharmacies dispensed a total of 4,065 million prescriptions, with an average of 12.6 prescriptions per inhabitant and a total cost of $379,247 million in the same year. Community pharmacy expenditures represented over 10% of U.S. healthcare expenditures. Public programs including Medicare and Medicaid and other federal and state programs covered over 50% of the pharmaceutical expenditures in the country. In 2015, community pharmacies dispensed 83.3% of the prescriptions and accounted for 68% of the pharmacy expenditures, while mail-order pharmacies dispensed 16.7% of the prescriptions and accounted for 31.9% of the expenditures. Pharmacy chains represented 41.2% of the stores, dispensed 62.7% of the prescription, and 71.6% of the expenditures of community pharmacy, while independent pharmacies represented 36.1%, 22.9%, and 14.9%, and pharmacies located in food and merchandiser stores represented 9.8%, 14.4%, and 13.4%, respectively. There were 305,510 pharmacists employed in the U.S. as May 2016, of which 184,550, that is 60.4%, worked in community pharmacies, 71,390, that is 23.4%, in general and surgical hospitals, 3,870, that is 1.3%, in electronic and mail-order pharmacy, 8,810, that is 2.9%, in physician offices and community care centers, and 36,890, that is 12.1%, in other areas of practice. Pharmacists are required to hold a baccalaureate degree in pharmacy and, after 2000, a doctorate of pharmacy, also called PharmD, that is accredited by the Accreditation Council for Pharmacy Education, abbreviated as ACPE, a national agency recognized by the U.S. Department of Education for the accreditation of professional degree programs in pharmacy and accreditation of providers of continuing education. The PharmD program typically requires between 2 and 4 years of pre-pharmacy studies and 4 years of pharmacy studies. Accelerated programs reduce to 3 years the duration of the pharmacy studies by going year-round with 3 semesters per year rather than just 2. The last year of the PharmD studies is composed of students' practice rotations in different pharmacy and clinical settings. To be licensed by a state, pharmacists must also pass the North American Pharmacist Licensure Examination, abbreviated as NAPLEX, organized by the National Association of Boards of Pharmacy, abbreviated as NABP. It includes the boards of pharmacy of the 50 United States, the District of Columbia, Guam, Puerto Rico, the Virgin Islands, Australia, Bahamas, 10 Canadian provinces, and New Zealand, and the state's practice standards and legislation examination organized by the state's Board of Pharmacy. Pharmacists may hold licensures from multiple states, and may transfer their license from one state to another, under certain conditions, but they must always hold the licensure from the state where they were originally licensed. Pharmacists must also complete several of hours of continuing education each year to maintain their professional competencies and fulfill the requirements established by the state's boards of pharmacy to maintain the pharmacist license. We will now discuss U.S. regulation of pharmaceutical care. The role of the pharmacist is regulated at the federal and state levels. The federal government is responsible for approval, regulation, and interstate commerce of drugs and biologics, enforcement of federal regulations related to controlled drugs, and certain areas of pharmacist activities related to the federal healthcare programs such as Medicare and Medicaid. Two federal laws, the Omnibus Budget Reconciliation Act of 1990, abbreviated as OBRA 90, and Medicare Prescription Drug Improvement and Modernization Act, abbreviated as MMA, of 2003 expanded the role of the pharmacist in the U.S. Omnibus Budget Reconciliation Act 90 required states to provide prospective drug review before an outpatient prescription is dispensed to Medicaid patients at the point of sale or distribution, and mandated states to establish standards for counseling of Medicaid patients by pharmacists in community pharmacy settings. Omnibus Budget Reconciliation Act 90 represented the federal recognition of the role of pharmacist in patient care and expanded the scope of pharmacy practice. The prospective review established by Omnibus Budget Reconciliation Act 90 must include screening for potential drug therapy problems due to therapeutic duplication, drug disease contraindications, drug-drug interactions, including serious interactions with non-prescription or over-the-counter drugs, incorrect drug dosage or duration of drug treatment, drug allergy interactions, and clinical abuse or misuse. According to Omnibus Budget Reconciliation Act 90 pharmacist counseling requirements, the pharmacist must offer to discuss the following with each Medicaid patient or caregiver who presents a prescription: the name and description of the medication, the route, dosage form, dosage, route of administration, and duration of drug therapy, special directions and precautions for preparation, administration and use by the patient, common severe side or adverse effects or interactions and therapeutic contraindications that may be encountered, including their avoidance, and the action required if they occur. Techniques for self-monitoring drug therapy, proper storage, prescription refill information, and action to be taken in the event of a missed dose. Omnibus Budget Reconciliation Act 90 also indicates that pharmacists are not required to provide consultation when patients or caregiver refuses such consultation. Omnibus Budget Reconciliation Act 90 also mandated states to ensure that a reasonable effort is made by the pharmacist to maintain a record including demographics, disease-related, known allergies and drug reactions, a comprehensive list of medications and relevant devices, and pharmacist comments relevant to the individual's drug therapy. The MMA established a voluntary prescription drug benefit for Medicare patients, the so-called Medicare Part D, that started in January 2006. The Medicare Part D program is managed by private drug plans under the regulation and supervision of the Centers for Medicare and Medicaid Services, abbreviated as CMS. The MMA requires drug plans to have in place a cost-effective drug utilization management program and a medication therapy management, abbreviated as MTM, program. According to CMS, medication therapy management is a patient-centric and comprehensive approach aiming to engage the patients and prescribers to promote coordinated care, comprehensive medication review and monitoring of medication therapies. The medication therapy management program aims to ensure optimum therapeutic outcomes and reduced risk of adverse events for patients through improved medication use. The medication therapy management program must be developed in cooperation with licensed and practicing pharmacists and physicians, provided by pharmacists or other qualified providers, and coordinated with any chronic care management plan. Drug plans must describe the resources and time required to implement the medication therapy management program and establish the fees for pharmacists or others providers. The medication therapy management program is required for patients who meet all of the following criteria. 1. Have 3 or more chronic diseases. 2. Are taking 8 or more drugs. And 3. Are likely to incur annual costs for Part D drugs greater than or equal to the specified threshold, $3,919 in 2017. Medicare patients may decline to participate in the medication therapy management program. The medication therapy management program requires performing an annual comprehensive medication review, abbreviated as CMR, and targeted medication reviews, abbreviated as TMRs, at least quarterly with follow-up interventions as necessary. The comprehensive medication review is a systematic process of collecting patient-specific information, assessing medication therapies to identify medication-related problems, developing a prioritized list of medication-related problems, and creating a plan to resolve them with the patient, caregiver and/or prescriber. The comprehensive medication review must include an interactive, person-to-person, or telehealth medication review, and consultation of the medications, including prescriptions, over-the-counter, OTC, medications, herbal therapies, and dietary supplements, performed in real time by a pharmacist or other qualified provider with a summary of the results of the review, and it may result in a recommended medication action plan. The states are responsible for regulating pharmacies, pharmacists, pharmacy technicians, and pharmacy practice within the framework defined by the federal government. Each state's Board of Pharmacy is responsible for education, licensing, regulation, and enforcement aspects of the practice of pharmacy in the state. As a result, the practice of pharmacy and the role of the pharmacist in patient care change depending on the state. The ownership and location of a community pharmacy are not regulated in the U.S. However, a pharmacy is required to have a pharmacist in charge, and a licensed pharmacist must be on duty while the pharmacy is open. All states mandate pharmacists to perform drug utilization review and offer patients or caregivers counseling during drug dispensing in order to improve proper use of drugs and maximize patients' outcomes. However, the language and requirements of counseling vary by state, but in general, counseling includes providing information about the purpose of the medication, directions for use, how to identify and how to proceed in case of occurrence of adverse effects, potential interactions and therapeutic contraindications, techniques for self-monitoring drug therapy, proper storage, refill information, and action to be taken in the event of a missed dose. There are 12 states: Colorado, Idaho, Indiana, Iowa, Nebraska, New Jersey, North Carolina, North Dakota, Tennessee, Texas, Utah, Vermont, that have incorporated the concept of pharmaceutical care as part of the regulation of the role of the pharmacist. States use the concept of pharmaceutical care similar to the one described by the American Pharmacist Association, a patient-centered, outcomes-oriented pharmacy practice that requires the pharmacist to work in concert with the patient and the patient's other healthcare providers to promote health, to prevent disease, and to assess, monitor, initiate, and modify medication use to assure that drug therapy regimens are safe and effective. Idaho, Illinois, New Hampshire, Oregon, West Virginia, and Wyoming have included in their regulation the medication therapy management concept. In general, the states use the definition approved by pharmacy organizations and associations in July 27, 2004, that consider medication therapy management as a distinct service or group of services that optimize therapeutic outcomes for individual patients, that encompasses a broad range of professional activities and responsibilities within the licensed pharmacists, or other qualified healthcare providers, scope of practice. The scope of medication therapy management services described by the states includes similar services than those mentioned by the Medicare Part D medication therapy management requirements. As of October 1, 2017, all states with the exception of Alabama have implemented collaborative practice agreements, abbreviated as CPAS. Collaborative practice agreements are a formal practice relationship between a pharmacist and a prescriber that specifies functions delegated to the pharmacist by a physician or, in some cases, a nurse practitioner or other provider. Collaborative practice agreements' functions vary from state to state, and typically include authorizing pharmacists to initiate, modify, and discontinue drug therapy, and ordering and interpreting laboratory tests. Next we will discuss pharmacists as a provider in the U.S. The provision of patient care services has traditionally been an important role of the pharmacist in the U.S. Clinical pharmacy evolved in hospital pharmacy in the 1960s, and, later, expanded to outpatient clinics. The traditional role of the community pharmacist included dispensing and consultation with prescribers and patients, and health education. And some might argue that the diagnoses and recommendations for treatment of self-care issues that pharmacists have been engaged in since the days that pharmacists were apothecaries could be viewed as providing patient care services. Unlike physician's assistants who work as providers under the direct supervisor and under the prescriptive authority of physicians, pharmacist works with physicians as providers in a collaborative fashion due to collaborative practice agreements. A collaborative practice agreement is a signed agreement between a physician or physicians with a pharmacist or pharmacists that allows the pharmacist to assess the patient's medication therapy and make changes to the therapy under certain restrictions such as the specific disease states and/or medications. As a way to create a systematic process of care, in 2014, the American Pharmacists Association and other stakeholders in the Joint Commission of Pharmacy Practitioners created the Pharmacist's Patient Care Process, 2014. Although this patient care process was created with medication therapy management in mind, it can be used for any patient care process that pharmacists are involved in. In general, the process has the patient at the center of the process and includes the broad components of collecting information, assessing the patient, creating a plan, implementing the plan, and monitoring and evaluating the plan via follow-ups with the patient, as shown in Figure 13.1. Currently, there are 38 states where pharmacists are designated as a provider in the state pharmacy code or Medicaid provisions. Since pharmacists are not recognized nationally as providers, the American Pharmacists Association and over 40 other stakeholder groups have been working toward the passage of legislation that would add pharmacists to the list of authorized providers in the United States Social Security Act. Although the listing of providers in the Social Security Act is primarily for the purpose of determining who can be paid by Medicare and Medicaid for patient care services, the vision is that private health insurance companies would also follow suit and broadly allow pharmacists to get paid for their patient care services. California has enacted legislation that created a new designation for pharmacist providers, called Advanced Practice Pharmacist, abbreviated as APH. As of August 10, 2016, pharmacists can be licensed as an Advanced Practice Pharmacist in addition to the traditional RPH, an abbreviation for Registered Pharmacist, designation. An Advanced Practice Pharmacist is allowed to perform patient assessments, refer patients to other providers, and operate as a collaborative drug therapy management pharmacist in collaboration with a physician. Additionally, the advanced practice pharmacist's role includes the ability to initiate, modify, and discontinue medications. Pause the video and carefully scrutinize Figure 13.1 illustrating the pharmacist's patient care process. Source: Joint Commission of Pharmacy Practitioners, 2014. Before advancing to the next slide. Next we will discuss the U.S. Bibliographic Review. Several large projects were conducted in the U.S. to assess the effect of pharmaceutical care on patient care and outcomes. The Asheville Project was a payer-driven and patient-centered program launched in 1997 by the city of Asheville, in North Carolina, to provide education and care management for city employees, retirees, and dependents with chronic health problems including diabetes mellitus, asthma, hypertension, and high cholesterol. The Asheville Project has been recognized as a healthcare model for management of chronic diseases. Patient care was provided by a team of primary care physicians, endocrinologists and other specialists, pharmacists, educators, and case managers with the support of data managers and administrators. Community pharmacists provided pharmaceutical care services in community pharmacies. Pharmacists accessed patients' health records from primary care physicians and communicated information back to physicians. The pharmaceutical care services provided in the Asheville Project resulted in improved patient outcomes, lower healthcare costs, fewer sick days, and increased satisfaction with pharmacist services. Project Impact teamed up community pharmacists, health clinics, and a mobile health unit to rural, underinsured people in the Appalachian region of southwestern Virginia. Pharmacists provided no-cost patient education about diabetes, medications, and self-management strategies. Pharmacists enroll patients in the program, conduct a diabetes assessment, and identify knowledge gaps. During bi-monthly meetings, pharmacists educate patients, record vital signs, and order lab tests. Pharmacists collaborate and communicate with other members of the healthcare team. The project impact has resulted in improved patient outcomes. Additionally, several systematic reviews, including mostly studies conducted in the U.S., have been conducted. The results of those reviews have found that pharmacist care interventions improve health-related quality of life, reduce medication underuse in older people, clinical and/or humanistic outcomes in patients from racial or ethnic minority groups, as well as improvements in specific diseases such as hypertension, heart failure, or diabetes mellitus. However, those systematic reviews also found limitations in the studies assessing pharmaceutical care that may limit the applicability of the results of the studies. Reviews examining the economic effects of pharmacist care interventions in the U.S. found a positive effect on healthcare costs. However, the reviews also found substantial limitations in the study's design and analysis. We will now switch gears to Canada. Let's begin with the community pharmacist in Canada. In 2015, There were 9,667 Canadian community pharmacies, representing one pharmacy per 3,745 people. There were 37,265 pharmacists employed in Canada in 2015, representing a pharmacist per 962 people. U.S. community pharmacies dispensed a total of 367 million prescriptions, with an average of 17.6 prescriptions per inhabitant and a total cost of $30,782 million in 2015. Community pharmacy expenditures represented 13.65% of Canada healthcare expenditures. Public programs including federal and provincial programs covered over 42.7% of the pharmaceutical expenditures in the country. The provinces and territories provide supplemental coverage for pharmaceuticals and other services and products not generally covered under the publicly funded healthcare system to certain groups of people, such as seniors, children, and social assistance recipients. Those who do not qualify for supplementary benefits under government plans pay for pharmaceuticals through out-of-pocket payments and private health insurance plans. Pharmacists are required to hold a baccalaureate degree in pharmacy accredited by the Canadian Council for Accreditation of Pharmacy Programs, abbreviated as CCAPP, or the USACPE. The pharmacy program typically requires 2 years of pre-pharmacy studies and 4 years of professional pharmacy studies. To be licensed by a province, pharmacists must pass the Pharmacy Examining Board of Canada, abbreviated as PEBC, qualifying examination, and the province's practice-based assessment and jurisprudence examination organized by the province's College of Pharmacists. Pharmacists must also complete several hours of continuing education each year. Next we will discuss Canada regulation of pharmaceutical care. The federal government is responsible for the regulation of pharmaceuticals, medical devices, and other health-related consumer products. The federal government regulates pharmaceutical products and the use of controlled drugs and substances. The regulation of the practice of pharmacy corresponds to the provinces. The scope of activities, regulations, training requirements, and limitations differ between provinces. The College of Pharmacists is the registering and regulating body for the profession of pharmacy in the province. The colleges enforce the legislation, standards of practice, code of ethics, and policies and guidelines relevant to pharmacy practice. The college also ensures that pharmacies within the province meet certain standards for operation, and are accredited by the college. Pharmacy ownership is not restricted to pharmacists and there are no restrictions to the establishment of a pharmacy in the country. Several provinces have granted prescriptive authority to pharmacists to initiate and manage drugs that require a prescription for sale following the diagnosis and professional intervention of a prescriber, Schedule I drugs, with the exception of controlled drugs, as shown in Figure 13.2. Pharmacist initiation of Schedule I drugs may be independent, Alberta, or through collaborative agreements, in Alberta, Manitoba, New Brunswick, Nova Scotia, and Saskatchewan, for minor ailments or conditions, in Alberta, Labrador, Manitoba, New Brunswick, Newfoundland, Nova Scotia, Prince Edward Island, Quebec, and Saskatchewan, for smoking or tobacco cessation therapies, in Alberta, Manitoba, New Brunswick, Labrador, Nova Scotia, Prince Edward Island, and Quebec, or in an emergency, in Alberta, Manitoba, New Brunswick, Nova Scotia, Prince Edward Island, and Saskatchewan. Pharmacist adaptation or management of Schedule I drugs may be independent, in Alberta, or thought collaborative agreements, in Alberta, Manitoba, New Brunswick, Nova Scotia, and Saskatchewan, allow therapeutic substitution in Alberta, British Columbia, Labrador, New Brunswick, Nova Scotia, Prince Edward Island, and Saskatchewan. Permit changes in drug therapy including dosage, formulation, regime, among other, all with exception of Northwest Territories and Nunavut Yukon, and renew or extend the prescription to ensure continuity of care, all with exception of Nunavut and Yukon. In some provinces, pharmacists can also order, in Manitoba, or order and interpret lab tests, in Alberta and Quebec. And, while Nunavut and Yukon do not allow pharmacists to provide any of the above services, it should be noted that these provinces account for the smallest Canadian populations at only 0.1% or 36,000 people each. Pause the video and carefully scrutinize Figure 13.2 illustrating pharmacist scope of practice in Canada. Source: Canadian Pharmacists Association. Pharmacist scope of practice in Canada. December 2016. Before advancing to the next slide. And now we will look at pharmacists as a provider in Canada. Pharmacists in Canada have been providing disease state management and pharmaceutical care services since the late 1990s, and have been expanding their roles ever since. Although there are no initiatives underway to have Canadian pharmacists classified as providers, survey research does show that consumers view pharmacists as healthcare professionals. This 2014 survey of 380 respondents in Newfoundland and Labrador found that 90% of responders felt that pharmacists were healthcare professionals just like nurses and doctors, and only 10% felt the main role of pharmacists was counting pills. In 2009, the Canadian Society of Hospital Pharmacists approved the statement, "CSHP advocates prescribing by pharmacists in the provision of high-quality, patient-centered care that is safe, effective, and accessible." The Meds Check program in Ontario is a government program similar to the Medicare Part D medication therapy management program in the United States. It is defined as a one-on-one interview between the pharmacist and the patient to review the patient's prescription and non-prescription medications. The Meds Check medication review will encourage patients to better understand their medication therapy and help to ensure their medications are taken as prescribed and that patients are getting the most benefit from their medications. Meds Check is a voluntary program for Ontario residents with a valid Ontario health card, who are currently taking 3 or more prescription medications a chronic condition. These patients are eligible for one annual review, and for a follow-up review within the year if they have a planned hospital admission or were recently discharged, based on a referral from a physician or nurse practitioner, or if the pharmacist determines there is need for a follow-up visit due to changes in the patient's medication profile, evidence of patient non-compliance, or if the patient has transferred their prescriptions to a different pharmacy due to changing their place of residence. Finally, we will look at Canada Bibliographic Review. Provinces have implemented pharmaceutical care programs in community pharmacy. In 2007, the Ontario launched Meds Check, a government-funded, community pharmacy-led medication review program for patients taking 3 or more chronic prescription drugs. The purpose of the program is to improve patients' understanding of their drugs and appropriate use. In 2016, Nova Scotia has implemented a community pharmacy medication review program reimbursed by the publicly insured Seniors Drug Benefit Program. Since 2007, pharmacists have been working with family physicians and other healthcare professionals as part of the North York Family Health Team to provide pharmaceutical care for patients in Ontario. Pharmacist care interventions in Canada have resulted in increased uptake of immunizations and improved chronic diseases adherence, outcomes, and costs. Thank you.